Hello, my name is Yeon from Korea University Anam Hospital. It is my honor to present our recent study titled Multiparametric MRI Features of Plasmacytoid Urothelial Carcinoma of the Urinary Bladder. Plasmacytoid Urothelial Carcinoma, or PUC, is a rare histological subtype of bladder cancer comprising only 1 to 3% of all cases. Histologically, tumor cells resemble plasma cells, which is the basis of its name. PUC is known for its aggressive behavior, early peritoneal spread, poor response to chemotherapy, and overall poor prognosis. Due to its rarity, PUC lacks sufficient clinical and imaging data, which makes diagnosis challenging. Cystoscopy often fails to detect PUC because of its flat infiltrative growth pattern, delayed or absent hematuria, and mucosal changes that can resemble benign conditions. CT and MRI are commonly used for evaluating bladder cancer, but studies focusing on PUC are scarce and lack standardized imaging protocols. There are only 2 case reports describing DWI findings and just 1 report on DCE MRI. Additionally, cystoscopy often misses subtle tumor features, leading to delays in diagnosis or errors in staging. Multiparametric MRI has shown high diagnostic accuracy in bladder cancer, and it's especially helpful in detecting infiltrative tumors such as PUC. Given this potential, our study was designed to describe the characteristic MPMRI features of PUC and to help achieve earlier and more accurate diagnosis of this aggressive and rare variant. This retrospective study included patients from January 2019 to August 2024. 13 patients with histologically confirmed PUC who underwent preoperative multiparametric MRI at our institution were included. All pathological diagnoses were reviewed by a dedicated genitourinary pathologist with 29 years of experience. All MRI examinations were performed using 3K scanners, including Siemens Skyra, Prisma, or Philips Achieva systems. The imaging protocol included T2-weighted imaging, diffusion-weighted imaging, and dynamic contrast-enhanced fat-suppressed T1-weighted imaging. 2 urologists with 24 and 7 years of experience independently reviewed the images. Tumor morphology was categorized as polypoid, sessile, localized, or diffuse based on the proportion of wall involvement. Signal intensity was assessed relative to the bladder wall or ileopsoas. DWI was graded as mild, moderate, or marked hyperintensity, while T1-weighted image and T2-weighted image were described as hypo, iso, or mixed signal. ADC values were measured in the solid tumor portion, avoiding areas of necrosis or bleeding. The clinical characteristics and MPMRI findings of the patients are summarized in Table 1. The mean tumor size on MPMRI was 6.3 or 6.4 centimeters, depending on readers, with maximum diameters ranging from 2.0 to 12.7 centimeters. PUC predominantly presented with localized bladder wall thickening or diffuse wall thickening with ill-defined margins. Among the 6 patients with diffuse thickening, 4 showed a markedly contracted bladder with a rigid wall resembling a Linnaeus plastic-like configuration. A polypoid or sessile morphology was observed in 2 cases. On high p-value DWI, the tumors appeared mildly hyperintense or isointense in more than half of the cases. The mean ADC value was 1.1. DCMRI revealed a progressive and prolonged enhancement pattern in 10 of the 13 cases. The remaining 3 cases, which had tumors smaller than 4 centimeters, showed arterial enhancement with delayed washout. Heterogeneous enhancement was observed in 11 cases, all of which were larger than 3.5 centimeters. 11 patients had a virus score of 4 or 5, indicating at least muscle-invasive disease. Pelvic peritoneal seeding was identified in 2 patients. No patient had concurrent upper urinary tract tumors. Histopathology revealed the presence of myxoid stroma along with fibrous components in tumors exhibiting localized or diffuse wall thickening. Inter-observer agreement was excellent for most qualitative imaging features, including the dynamic enhancement pattern and virus scoring. The agreement for the WI C-line intensity was good. Our study revealed the aggressive nature and morphology of PUC. Muscle-invasive disease was present in 11 out of 13 patients, and suspicious lymphadenopathy was observed in 3 cases. Pelvic peritoneal seeding was also found in 2 patients, highlighting early extravesical spread. Morphologically, PUC often showed diffuse or localized bladder wall thickening, sometimes mimicking a Linnaeus plastica-like bladder. In contrast, conventional urothelial carcinoma, or CUC, more commonly present with polypoid or sessile masses. In our study, more than 75% of PUC cases showed progressive and prolonged enhancement, which differs from the only peak and washout pattern typically seen in CUC. However, this finding is not specific. Similar enhancement can be observed in other aggressive variants and even benign tumors like hemangioma or leiomyoma. Thus, enhancement kinetics should be interpreted alongside morphological and clinical findings. These kinetics likely reflect the myxoid stroma, which has low vascularity and high water content, leading to gradual and heterogeneous enhancement. On high p-value DWI, PUC often shows mild hyperintensity or even isointensity. The mean ADC is relatively high, likely due to the presence of myxoid stroma, which facilitates water diffusion. Smaller tumors without myxoid stroma may resemble CUC, showing early enhancement and delayed washout. Compared to high-grade CUC, which typically shows low ADC and strong restriction, PUC's higher ADC with only mild restriction can be a diagnostic clue. Diagnosing PUC can be challenging because cystoscopy or biopsy may miss it due to diffuse infiltrative growth and low cellularity. As a result, it is often underdiagnosed until radical cystectomy. Multiparametric MRI may raise early suspicion, particularly in cases with diffuse or localized bladder wall thickening, progressive enhancement, and mild diffusion restriction. A virus score of 4 or higher can also be suggestive. Since PUC responds poorly to cisplatin-based chemotherapy, upfront radical cystectomy is often recommended. This study has several limitations. First, the small sample size reflects the rarity of PUC and limits generalizability. Second, the retrospective single-center design may be introduced selection bias. Third, the use of multiple 3T MRI systems could have affected the WI signal and ADC values despite standardized protocols. Finally, stromal content was not quantitatively correlated with imaging features on histopathology. In conclusion, multiparametric MRI provides valuable insights into the imaging characteristics of plasmacytoid urothelial carcinoma, many of which can be attributed to its distinct myxoid stromal composition. To further enhance diagnostic accuracy and treatment planning, future multicenter prospective studies with histopathology correlation are warranted. Thank you for your attention.